really learning from, thank you, really learning from the people who experience or communities that experience disparities to think about how I can collaborate with them to change that. So thank you for having me. Let me see. There we go. Okay. So I have two objectives. So after this presentation, I'm hoping you'll be able to define community engaged research and how it adds value to primary care, and understand and how to engage in community engaged research at Maine Health and what resources are available to you. We have them and they're growing. So this is just a brief introduction. You can see this map. All those little stars are places I've lived and been. I grew up in Southern California, did undergraduate and medical school in Northern California. Then I went to Boston for residency. Then I went to Chicago, where I worked at Cook County Health and Hospital System for 12 years. And then to the University of Wisconsin School of Medicine and Public Health. And most recently, right before joining here about 2 years ago, I was Chief of Primary Care and Value-Based Health at the New Dell Medical School in Austin, Texas. So I've done community engaged research in Wisconsin, Texas, and Chicago. And I'm just going to give you a couple examples so you kind of know a little bit about me. Number one, you see also on the top screen, you see someone working with an interpreter. So one of the areas that I started working in from the beginning of my career as a fellow was looking at the impact of providing adequate interpreter services on healthcare outcomes, cost, and care. And I still do work in that space. Through my work doing work looking at advancing health equity, I have had the pleasure of working with so many mentees and junior faculty and peers and senior colleagues who share that interest. And so to the right, you see on the bottom, you see a group of, I was actually just emailing them. We're still trying to get a paper out from a qualitative research we did with the Hmong population in Madison, Wisconsin, looking at their experiences understanding or challenges understanding the value of cancer prevention screening and cultural issues. And this is a team, 3 Hmong students, one Korean graduate student who worked with me on this. So really interested in also bringing in the next generation of scientists and healthcare providers and helping them achieve their goals. And then you can see this map of Wisconsin that Wisconsin is also a very rural state like Maine. And I have done community engaged research with rural communities in Wisconsin. And I hope that that wonderful experience I had, we actually won an award from the chancellor for the University of Wisconsin for an academic community partnership for that work. And so really excited to be able to bring that experience, particularly with rural communities, here to Maine. So that's just a little introduction to me and some of my interests. And I hope if you share any of them with me or have questions about it, please reach out to me. I love research. I love helping mentor people and things like that. So I just want you to know a little bit about who I am. So if any of that inspires you and you want to reach out to me, please do. So now I'm going to talk a little bit about what community engaged research is. So this is a definition from the NIH. Community engaged research is the process of, sorry, I have to move this. Oh, sorry about that. Is the process of working collaboratively with groups of people affiliated by geographic proximity, special interests, or similar situations with respect to issues affecting well-being. So a lot of times when people think about community, and one of the things that I actually really appreciate and wish other areas of medicine focused on was community, because I know for family medicine, this is something that you have to learn about in residency, and it's a huge principle of family medicine. So I wish we did more of that in other training programs. But so I think you know a lot about it. And a lot of times when people think about community, they think, oh, you know, out there. But you can have a community that can be a community of investigators or a community of family medicine physicians, let's say, who wants to understand what are the challenges a community of family medicine physicians has in actually conducting research. Let's say, I'm just throwing that out there as an example. So that's a community you could engage. Community can be, as is defined here, special interests, similar situations, geographic proximity. So really want to make sure we keep an open mind as to what community means. And the goal of this type of research is to contribute to innovative work that's focused on addressing the needs of that community. It can take many forms. Most commonly, people think about community advisory boards. It could be stakeholders as part of a research team. So you might have one or two people, not an entire board who's actually embedded in your research team. Or it could be true community-based participatory research. That's the kind of research where the community is an equal partner, may even be the leader in some instances, but it cannot be less than equal, the relationship you have with the community that you're partnering with, to truly work together equally on equal footing to achieve a research goal. I'm going to talk a little bit later about how it can occur at any point or throughout the process. And one of the keys is building trust. These relationships have to be bidirectional and mutually beneficial. So a lot of where community engagement goes wrong is when an investigator or academic goes to a community and says, I want something from you. And they're not thinking about what is the value to the community, how do you respect the community or that individual's expertise, et cetera. I'm going to talk a little bit more about that now. So why do it? So it makes research better on many levels. Obviously, as I have in the third bullet point, it makes your research more pragmatic and likely to be able to be disseminated. I mean, if we sit in our ivory tower or in our clinic and we think we have an idea that might help a community, but we don't go to the community and say, would you engage with this, or does this make sense to you? Can I communicate it well to you? If we don't do that, we might create something that just completely falls flat, will never be adopted. So obviously, communities are really essential to thinking about the problems that they face. It also builds trust. I know that when I worked at Cook County Health and Hospital System, I cannot believe I did work looking at trust, a qualitative study of trust and in medicine among Black patients as well as those identifying as Latinx. And I cannot tell you how often participants said to us, I don't want to take your money, because we had incentives and things like that. They said, but you know what? No one ever asks us what it means to trust you and to trust a healthcare system. Thank you so much for asking these questions. And so that was building trust by saying, I want to hear your perspective. I want to know your experiences because I want to help make it different. And so it can build trust with communities. Funders like it, so and may require it. So the Patient-Centered Outcomes Research Institute, PCORI, actually requires stakeholder engagement. And it brings diversity, promotes equity, and creates an inclusive research environment. And I meant to edit this here, but I didn't. But it also is a form of justice. Really, like, many of you may have heard this term, colonization in research. So a lot of times, white people or people of privilege are doing the research, get the names for it, get the recognition, gets the grants. And some people portray that as a type of colonization of research, which you can see why. And so doing community engaged research makes it decolonizing and promotes justice. So I really like this quote from Valerie Billingham. It's a quick and easy way to remember why I do this. Nothing about me without me. I think that's pretty self-explanatory. So what are some of the principles of community engaged research? So number one is collaboration and shared purpose. You are going to be collaborating with people. You are going to see them as collaborators. You're going to treat them as collaborators. And they should be really clear on what you're asking them to do, so that when they engage with you, they know that you're collaborating on a shared interest or a shared purpose. Co-learning and equitable power. So a lot of times, those of us coming from a healthcare background, a research background, a background of privilege, we think we know what we're doing. We don't. It's hard for us to share power. And it's really important when you go into a relationship with community and community members that you think about, number one, you have so much to learn from them. One of the things that I always like to think about too is, what can I bring to the table that they want to learn about? So learning about research, learning about how do you talk to doctors when you disagree with them might be something that they want to learn from me, et cetera. So I think it's really important that we respect that co-learning process, and that we respect people's opinions and desires to influence what happens in research. And there have been times I want to do something in a community that is probably the best type of research design, let's say a randomized controlled trial. And the community says, no, that's not acceptable to us. That would not be acceptable for us to like participate in this research if you're going to deny one group of people something that we think will be of value to them. So we have to think about a different design. And that's a way in which I cede power to them because they know the community best. I had to be open to that learning and open to what they had to share with me. And I have to be open to what they want to teach me. Transparency and trust. So it's really important. I think I know that I ran into trouble previously, and I learned my lesson through this error, is that sometimes we're so busy when we're working in an academic environment, we're trying to meet the needs of a funder, we're trying to meet the needs of our academic organization, that we forget to make sure that the community members are kept aware of what's happening all along in the process. And that's another way to build trust. Community members and community-based organizations really care about impact and action. This is another way in which I've had to modify some of my research previously, and have to recognize that sometimes when I need the community organization or individuals to do something that's a requirement, let's say, of the IRB or of a funder, that I have to give them adequate time to do it because they're out there trying to do impact and action, not meet some of these academic requirements and trainings. And so it's really important to recognize that and also to say, okay, when I want to engage community, what they care about is impact and action. So how am I going to bring that value in the research that I'm trying to work with them on to pursue? And then this is really, in the end, for community-based participatory research, I think we should all think about, which is we take equal responsibility of input of work and output of results. So we need to, but with a caveat, which is leveraging the expertise of some more than others where appropriate. So, in my community engaged research, if I talk to them about, oh, should I do multiple imputation for missing data, they're going to be like, I don't know. It doesn't mean that much to me. Or it might be, they might say, no, people have some sophistication, a lot of people have sophistication around research too. They might say, we don't want you to substitute missing data. We have to present the raw data. That's really important to our community. So there's ways in which you might leverage different expertise and take unequal power sometimes in the relationship because one person has, or one group has more expertise than the other. So what are best practices and what can go wrong? So I already spoke to this: respect the community and expertise your collaborators bring. Don't act like you are checking the box. So I have people come to me and they say, oh, I need to form a community advisory board because NIH is asking for it. And I go, okay, what are you going to ask them to do? What's the purpose of actually forming this community advisory board? We can't go out and invite our community members to participate with us unless we know what we're asking of them, and they can be informed when they decide to engage or not engage. So this is a common problem that people aren't thinking about that. And we'll get into resources later about how there are people around our organization who can help you think about how to do that in a meaningful way. And then pay people for their time and expertise. This is another thing that we don't think about. Like they're like, we want something from the community, to be frank, a lot of times getting their feedback. Well, they're giving you their time and their expertise. And that time and expertise is valuable and it needs to be compensated. Really important to communicate clearly and frequently, as we spoke about. And I think it's also really important to think about this communication being cross-cultural. So an example from my own experience was I did a very large national study through PCORI, actually. And I worked with 3 community-based organizations that provided peer support to older adults. And I was asking them for something and they were not providing it, or I thought they weren't providing it. And I had someone working with me who was kind of a cultural broker between the two of us. She understood academia, but also worked very closely with these community-based organizations. And she said, there's this tension going on. And I was like, there is? And she said, yes, here's the tension. And I said, oh, well, I thought they haven't given me an answer after I asked. She's like, no, they gave you an answer. You just didn't understand that was the answer, because it wasn't like, no, it wasn't direct. It wasn't like, and I said, okay, that's very helpful for me. Can you help me understand when I may not be hearing something that they're saying, because we speak kind of different languages. And then it's really important to recognize historical mistrust and don't take it personally. And I'll get to the little caveat under that, but we may want to do work in communities where, or with communities, excuse me, where they don't trust us. And it's going to take a lot more time to develop that trust. And it may have something to do with us. It's always really important to be humble and say, did I do something? But a lot of times this is deeply embedded mistrust. And I kind of don't like the word historical here, because it's really based on both history as well as contemporary experiences people have in our nation. And so just recognize that that's something that is a problem that we need to work on. And then don't do helicopter research. This is a way in which you can create distrust. So what I mean by helicopter research, for those of you who haven't heard that term before, is where you helicopter into a research, into a community, you do the work, but you don't really change the community, you don't provide resources, you're not thinking about creating a relationship, and then you just helicopter out. And so it's just kind of using the community essentially, and that creates a lot of distrust. Many academic organizations have been guilty of this. And one of the reasons why I'm really passionate about building opportunities for people to learn about community engaged research here at Maine Health and in Maine, and have some coaching around that, is so that we don't do that kind of research. All right, so when should you do it? So this is really what's called the translational spectrum, from T1 basic science to T4, which is population health research. And honestly, you could probably do it at each of these steps. Most people think about population health research or implementation in clinical settings, but you may want to know that if you're thinking about a type of therapy, you may want to engage community just to even direct your basic science. Let's say you have an opportunity to go in two different directions with your basic science, and you want to know what's going to be more important for the people of Maine. You may want to bring in community advisors to help you think about that. That's an example with basic science. Later, clinical testing. Thinking about how you describe something to someone as that might be a phase 1 or phase 2 trial. Community can help you with that. So you could really do it at any stage of this translational spectrum. So here's some examples of where you could bring community engagement in. It could be out through the entire process. That's kind of how I like to do it. Real, true community-based participatory research, but it could be in the grant writing, the study design and planning, reviewing informed consent documents, commenting on research protocols, interpreting study findings, disseminating research results. I think what would be a mistake, however, is to engage someone in grant writing and then not give them an opportunity to be involved in the research moving forward. So you'd want to think about that. How do you build trust and relationships? And speaking about this, reviewing informed consent documents, this community research engaged research group, we call ourselves CREW, has been meeting and is going to meet regularly with the IRB, members of the IRB, because sometimes there's a tension, as many of you know, between what we really need to put in an informed consent document versus what might be acceptable to community. So we're working with them, in what ways can we bring the community voice in to this and other materials? And so some of you might think, oh, could we do something in this space? And we're working on creating more flexibility and trusting our expertise and community engaged research within our scientific community and IRB here. So here are a couple resources that you can have that exist. We have this infrastructure that has been supported by both the Northern New England Clinical and Translational Research Network and then the Acute Care and Rural Health Research COBRE. COBRE stands for Center of Biomedical Research Excellence. Sorry about that. I'm just going to talk briefly about some of the resources. So this is just showing our mission, and this, the PI local to Maine is Cliff Rosen, and the mission is to enhance the people of Maine, the people of Northern New England through these 3 states you can see here by fostering and coordinating clinical research, education, and community engagement across these 3 areas. 3 states, excuse me. And then the acute care research and rural disparities is to better serve rural communities by developing statewide research and care network in Maine that addresses barriers that are associated with limited resources, expertise, and access in rural communities. As you can see, there's a number of partners in this study. So what are we doing? In the Northern New England Clinical Research Network, we have this Rural Health Research and Community Engagement Core, which is now just going to be called the Community Outreach and Engagement Course. And then we have the Community Engagement, Bioethics, and Outreach Core that's part of the Acute Care and Rural Health Research. One of the great things about this is NIH says it is really important that you do community engagement. And so in each of these grants, they're providing money to support it. And together we work, oops, that animation did not work. But anyways, together we formed this crew group. You can see a number of people that you might know on here. Just briefly, myself as an investigator, Neil Corson, also investigator, Elizabeth Verda, who is really leading community engaged efforts and is now research program director at CORE, Carrie Sullivan, who's a rural community engaged research navigator, along with Emma Daybranch, Kat Futz, and Amanda Lassard are research navigators within that acute care COBRE, and then Gloria Scar, who's leading community engagement for this large study we have called Radix Up, and Liz Charnetsky, who brings scientific expertise as a community engaged researcher. And then this is, not all of us were on that slide before, so this is the Community Engagement and Bioethics and Outreach course. So Francesca and Rich Riker are also working on these efforts. So that's just some names and faces for you. So we have really developed this new conceptual model of community engaged research. So this is another cultural difference, I would say, between people at community-based organizations or in community, or many cultures, frankly, are not linear thinkers like we are as scientists or healthcare providers or in our Western culture, honestly. So we took this diagram, which is a model for increasing community engagement, which is really like linear, which is outreach, consult, involve, collaborate, and shared leadership, and changed it to be one that really more fits what we're actually doing, which is in the middle, we put what we want to do as part of this structure, and that we all have the shared goal, as we talked about in purpose, collaboration to advance research, promote health equity, and improve patient and public population health outcomes. And then we have these different partners, healthcare organizations, academic research centers, public health and community-based organizations, and patients and families and community members. And really, it's not a one way, it's not one, there's communication that revolves around and among all of us to really to make it a more inclusive, equitable model. So if you haven't seen this, this is a new figure that's in this Assessing Meaningful Community Engagement, a conceptual model to advance health equity through transformed systems for health, which is a publication, new recent publication from the National Academy of Medicine and Sciences. And it's really showing how community engagement and research can impact care delivery. And it just really talks about many of the things we talked about. So in the green are the core principles. I spoke about all this: inclusive, culturally centered, financially, equitably financed, shared governance, et cetera. And that through that, you can build out change that changes on our drivers of health. So it can help you strengthen partnerships and alliances. It increases expanded knowledge. That comes where that bidirectional learning comes in. We talked about community ready information. This can help improve health and healthcare programs and policies. So we would create community aligned solutions. They'd be actionable, pragmatic, as we talked about earlier. And then that really gets us to what we all want to achieve, which is that our communities be thriving, as it's outlined here. So where are we going next? These are some of the resources. So we're going to engage investigators and research to address health disparities and inequities in Northern New England. And we're going to learn about community priorities. That's the second bullet point. And really engage investigators. Instead of like taking investigators to the community, we're trying to bring the community in as well to say, here is what communities have prioritized. You have some expertise in this area. Can we help you work with community to do research that's relevant to their needs? And then we also want to increase the dissemination of research findings in partnership with community. And part of what we're going to do is establish these regional community engagement councils that are for research. Speaking of dissemination, in addition to thinking about research and helping people do better research, I just talked also about helping us making sure that the community, we meet their needs, but I also see this as an incredible opportunity to increase understanding about science and scientific literacy. I think one of the issues that we face with COVID is that people don't understand that science is iterative. They don't understand that science builds on each other and that you get better and better. And that's why, for instance, COVID recommendations got narrower and more specific because we were able to learn. It's a process of ongoing learning. And so I think increasing scientific literacy is an advantage of this kind of community engagement. And then we're going to expand partnerships to increase the ability for us to do community-based research projects, so academic centers, rural health practices, FQHCs and community organizations, and then this Northern New England practice-based research network I'm going to mention briefly. This is just showing where we're going to do the community engaged research councils. And then we already have one really in the Portland area that we want to continue related to the needs of high-risk populations, particularly those who are newer to Maine, may not speak the language, experience health disparities related to homelessness or use of IV drugs. So those are some things that we're going to be working on as well. So I wanted to make sure I had an opportunity to talk a little bit about the opportunities for primary care research and then open it up for questions, because you might have questions for me like how I want to do this research. How could I do it? How can you help me at the Research Institute? So, okay, so you know Adam, I saw Adam's on the call here. So he and Deb Rothenberg have been talking to me about how can I help them think about doing more research through the Preble Street Learning Collaborative, which we're working on getting something set up on the a meeting set up. And we've been talking about this for a while, but I think it's so great. Here's an innovative care model where we're really meeting the needs of a community through family medicine. And the question is, how do you then document or see what the impact it's having on your learners, on your faculty, on the perceptions of people experiencing homelessness, let's say, or the people themselves, like what kind of care are we providing? Is it meeting their needs? So that's an example. Then over here is just a picture of the Dartmouth Co-op Practice-Based Research Network. This is you're going to see some familiar faces on here. I think Neil's in here somewhere. I can't remember. There's Beth. Oh, so sad Beth left, but there's Beth. So you'll see some familiar faces on there. But this is a great network in which these practice-based research networks are actually designed for people who work within them or really interested in primary care practice, let's say. What are we doing? Are we meeting the needs of our patients? If I make this tweak, let's say a quality improvement tweak, and I maybe do it in 2 of the centers, but not other 2, does it change versus those other centers? And people doing practice can ask questions about practice and their patients, and that the network will actually have resources within it to help answer those questions. So maybe a research coordinator, access to analysts, a way to pull data. So we have a meeting this afternoon, actually, I'm going to miss somebody's talk, to go to how we're going to be able to create a common data model and create a warehouse where maybe we could ask primary care questions, inquiry that data warehouse of those questions. So that's an incredible resource that's also being strengthened and built out right now. We're dedicating more money to it. Beth was able to actually get some money through Dartmouth, or a commitment from Dartmouth, to add some resources as well. So this is a great resource now, but it's going to be even better in the future. And then I want to point out that the Agency for Healthcare Research and Quality, I want to point out at the bottom, you see primary care. There's a new Center for Primary Care Excellence run by Patrick O'Connor, who I happen to know is a great general internist. They are now really interested in, and I have really good news that they actually got, after many, many years, Congress has provided them with more money to do their work than they have in the past, which is actually pretty wonderful and dramatic, because this is one of the only places you can go to get federal funding for kind of doing primary care research. But I just want to, these slides are going to come out to you, so you can go, but you can go to AHRQ and Google primary care research, so you can see there's primary care research career development awards. So if you think about, do you want to have a career in doing research that's related to primary care? How do you improve organizational health literacy to prevent and manage chronic diseases? Fabulous coming out of the preventive medicine and leadership program. So all these, so there's some, this is just one opportunity that I'm presenting to you. And then I just want to let you know that we are here to help you. So, you know, first of all, there's funding. So one of the things I want to tell you about the COBRA and the NNECTR. I don't know why I didn't put the NNECTR, but every year there's pilots available up to $50,000 actually to do research related. So NNECTR, the Northern New England Center for Translational Research, that actually has, it's broader because it's not funded for acute care and rural health disparities like the COBRA. And then there's also a metabolic COBRA that's focused on metabolic diseases. So you could think about like applying for that. There's this Hillman Award, which is for medical students, fellows, or junior faculty, or residents, if residents, to spend 80% of their time in a year dedicated to research, to kind of take out a research year. We have mentored researcher grants, again, for fellows and residents, as well as junior faculty, to get funding to do research. And then the Tufts Center for this Tufts CTSI also has a number of opportunities we can take advantage of. So just want to let you know that there's funding. And then we provide support around how do you apply for that funding? How do you write a budget? There's the resources through the Center for Outcomes Research and Evaluation. Its name is changing soon, to the Center for Interdisciplinary Population Health Research, to better communicate what that center does. But in there we have data analysts, we have people who, and qualitative data analysts. There's research navigation. Some sits within that center and some sits outside the center to help with how would you design a study, as well as, you know, can you help me get through the IRB? What does the IRB need if I've never submitted a protocol to the IRB? So there's lots of resources that we have, and this is just a few of them to help you do your research. So that is the end of my presentation, and I'm going to stop share so I can see better, and I'm available for questions or comments.
Thank you, Dr. Jacobs, for that amazing talk. I'll open it up for questions for anyone on the Zoom or anyone in the room. I can repeat it, or you want to come up? Oh, there it is.
I don't know. Does that work? Hello? I don't know how to tell if anybody can hear it.
Can you hear?
I can hear you. I can hear you, Tina. Yeah.
Okay, great. So I just wanted to say thank you very much for zooming in. And I wanted to say to everybody who's here in the Dana Center, thanks for coming in person, because this is so exciting to be able to present the third year fellows work after that wonderful talk. I'm actually going to turn around. So because I'm looking at myself back. Anyway, I kind of wanted to just thank you for that overview about your own background and also the path that people can go through. And I wondered if you could share a couple of ideas that you have for how to integrate the beginning ideas that people have with the other challenges of their clinical time. So if there's ways that we can encourage residents and med students, as well as our faculty, to pursue their ideas. And you began that commentary when you were talking about the CTR in the Northern New England program, but can you also just share a little bit about other resources and the other clinical people that you know about in primary care that aren't just in family medicine? Thanks.
Yes. So one person who's also in primary care, it was an excellent researcher and quality improvement expert, is Kathleen Fairfield. And so in the Department of Medicine, so Kathleen and I worked together on a number of different COVID related grants to actually address health equity. And so that's someone who comes to mind. We have, I'm trying to think, one way I think is so this is a common issue within our organization right now, which I hope is changing with our new leadership under Andy Mueller and Aileen Mickey, is that we need to have a compensation model that allows people to have time to answer some of these questions and do scholarly work, be it research, education, or innovation, or other scholarly work that they want to do. And so I think for faculty members, that will be of help in the future. And I think we're going to get to that model, which I'm very excited about. In the meantime, I think an excellent way is to partner with someone who is a PI, a principal investigator, who actually has time, who can help you reach your research goals. And sometimes research navigators can be that collaborator. So you could go to them, if you like, you could go to them and say, I have this research idea, and then they can help you with different aspects of it. And then we need to figure out, like, if you need to collect data, how do you get that data? If you need a data analyst time, how do you get that analyst time? And we do pro bono work, so to speak, like we do that work without funding, but it is better if you get one of these pilots, let's say, and get funding. And so, because then you can buy out some people's time and they're more available, just because we have to prioritize the funded work. So those are some ideas of ways to actually get people the opportunity to engage in research and do it and like make their ideas a reality.
Thanks so much for that. What other questions do people have?
Trying to see if anyone has their hand raised. I don't see anyone's hand raised.
Come on up.
So my other question or comment, and it's kind of for those of you who are about to do your presentations, but it's also maybe to just ask you, Elizabeth, about your experience of people taking the little tiny rocks in their shoe from their clinical experience and being able to say, I want to ask this question and I want to answer it. And I'm wondering if, you know, the presentations that we'll see this afternoon all started like that, and we're very proud of the work that all the residents do year after year, but particularly right now with the changes that you're seeing with the CTR, are there other primary care questions that you see currently being asked that we might need to be aware of so that we can better collaborate?
Yes, thank you for asking me that question. Right now, there's a couple of different things going on. Number one, there are two pretty large telehealth grants that are from HRSA, and they're not exactly research, but there is a research component to it. And one of them is about increasing access to care for people with diabetes. Very relevant primary care question. So the question is, could someone maybe collaborate with Tracy Halbuena, who is the PI of that work? You know, that's one idea. Similarly, Dr. Erwin Brodsky and Dr. Kiran Gujral in endocrinology received a grant from this organization called the Helmsley Foundation. And they're partnering with DreamEd, which is a continuous, it's a company that makes a continuous glucose monitoring system that also incorporates AI to help better manage people's diabetes if they're on multiple insulin injections a day. And so they're just starting out, and there's great questions about that. Like, how do primary, and so the idea is how do we, since I think there's a really small number, I should know this number because I've seen it, I can't remember, there's a very small number of endocrinologists in the state of Maine. So the idea behind this is, how do we increase the ability to provide really excellent, like high quality care to people with diabetes if a primary care physician's like, I don't know what to do, I need advice from an endocrinologist. And so there's going to be this virtual diabetes clinic, they call it, using this continuous glucose monitoring system to try to help get advice about how to do it so that primary care doctors can feel more empowered and feel more confident in their ability to take care of people with this kind of hard to manage diabetes. And so there's so many questions in there. They're going to be interviewing providers and practice people and patients. Do you like this? Was it helpful? What could we do better? You know, what did you think of the technology? Plus, they're going to be asking questions about outcomes. So, I mean, that's another great opportunity. And I'm working closely with Kieran and Erwin. And so if someone wants to be engaged with that, I'd be happy to make an introduction, have you come to team meetings, things like that. So those are two examples in primary care that I can think of off the top of my head.
Thanks so much. We were muted, but Tina said that was great. So thank you for that answer. What else?
I'd be curious, has anyone in the room done community engaged research, and what was their experience like? What did they learn from it?
Anyone here or anyone on the Zoom who wants to speak to that? Tina, you can talk again.
Okay. Tina and I are like on a panel. You're learning from our dialogue,
Well,
which I love.
I was staring in the back of the room for Deb, and she's walking forward, which is good because I want her to say something. But I also wanted to say that some of the previous years' residents have done community engaged research and gone to communities over the time that they had time to work on their projects, and then brought that forward. And we definitely haven't had the direct experience of longitudinally engaging with any individual communities through the research work, but we have certainly done that through the program. So that's why I'm glad Deb's here.
Thank you. Thanks for that great presentation, Liz. I really enjoyed it. Community engaged research for me has taken multiple forms, one of which was anthropology dissertation, and the others have been with residents along the way here. I think one of the challenges is time and is an ability to be flexible in your goals, which will change as you engage with community and actually realize what their questions are. Some of the more community engaged projects that our residents have done have really much more been not necessarily resulted in a research result. They've been, I'm thinking of Camia Dimmock years ago, who did a project where she designed Our Body Ourselves type talks to give at Maine Access Immigrant Network that were amazing to watch and see these communities, a couple of tables in the room where the Camia would say something and then it would get translated into French, Arabic, or Somali. And then the questions would come back that were different from each cultural group, it seemed. But there was no research outcome that came with that. And I think that is an illustration of the kind of time it would take to make a research outcome come with that. And that is one of the limitations of doing this, these residence projects in a timely manner. Community engagement feature seems to me and part of how we get stuck with it is that it's a longitudinal, long-term engagement. If you're not going to do the helicopter stuff, which I really appreciated you referring to, Liz, then you need to stick around. So I would think if we were going to do that, we would need to have a way to hand off the continuity of the project, because it's not realistic to have it done in the time frame that it takes for residents to do it.
Those are such really good points. I'm so glad you brought them up. It does take a lot of time. That is one of the reasons why we wanted to create these community engaged research councils. And then we were just on this crew meeting, the community research engaged work group. And we were talking about, so one of our faculty, or our staff scientist, Mike Kohut, you may know him, he does a lot of qualitative research. And there's a lot of qualitative data that's out there that could still be used to actually look at questions about what community members need or what's being brought up in the community. And he wants to actually create a kind of a community engaged research group around the areas that he's worked in a lot. So then that would also be a way to do continuity. Like, we maintain the relationships. People come in, like residents come in and say, this is what I'd like to answer this question. Okay, we have data, we don't have data. Let's help you collect the data. And then we have ongoing relationships, because I think we as the faculty members or the research institute can also be the continuity there. But I think that is such a great idea too, to think about, could you have how do you maybe pass off projects or ability, to different resident classes, let's say. Although another really important principle is that someone does work in what they're really interested in doing, so that because then they're going to be more committed to it. And but thank you, Deb. Those are really excellent comments. Thank you.
This talk is so inspiring, largely because community and the impact on our patients and the different communities we care for is so central to family medicine. And so it's so exciting to think about what are ways that we can both be curious about something, which I've heard Tina say time and again, and have this meaningful impact where we're working with and for our communities in a different way. So thank you for inspiring us and for sharing your ideas and letting us all know how we can be involved more. And I know that we all look forward to partnering with you more. But I want to, on behalf of all of us in the room and everyone on the call, thank Dr. Jacobs for her time. I know that lots of people on the call have a busy afternoon of other things that you need to do. So if people need to drop off to go back to your clinical or other work, feel free to do so. I hope lots of you will stay on for our scholarly projects from our third-year residents. And I'm going to pass the baton to Tina Holt to kick things off.
So thank you very much, Allison. Thank you, Liz. Thank you, everybody. Oh, look, suddenly all of the R3s are here. That's great. So I was going to say we could give everybody just like 2 minutes to get that transition from wherever they were to being here. And we'll start to pull up the slides, and then we'll get started with our afternoon activities. Or we'll continue with them, but we'll start with all you guys.